Lakeland Currents, your public affairs program for North Central Minnesota. Production funding for Lakeland Currents is made possible by Bemidji Regional Airport, serving the region with daily flights to Minneapolis-St. Paul International Airport. More information available at bemidjiairport.org. Closed captioning for Lakeland Currents is sponsored by Nisswa Tax Service, tax preparation for businesses and individuals. Online at nisswatax.com.
Hello again, friends. I'm Jason Edens, your host of Lakeland Currents. Thanks for joining the conversation today. And of course, thanks for your ongoing support of Lakeland Public TV. How would you feel about sharing your healthcare details with a robot? And what if I told you that if you did, you might actually enjoy a better health outcome? A recent study has revealed that Google AI can actually outsmart and outperform human experts in the diagnosis of some cancers. Lab automation would provide quicker test results for patients. Process automation could theoretically reduce the cost of healthcare. Robotics and machine learning offer a lot for medicine. There's a lot of promise, but they also raise a lot of questions as well. Now, this is not the stuff of the future. This is happening in our region today. The Cuyuna Regional Medical Center has recently hired or acquired an orthopedics robot. And here to help us better understand the role of robotics and automation in medicine is my guest, Tom Lewandowski. Tom is a physician assistant in orthopedics at the Cuyuna Regional Medical Center. Tom, welcome to the program, and thanks so much for making time.
Hey, Jason, thanks for having me.
Absolutely, it's great to meet you.
You too.
So first of all, before we get started on robotics, let's remind everyone, what is orthopedics?
Orthopedics is, bone and joints, and we do a lot of joint replacements people wear out over the years. So I specifically work with Dr. Eric Severson, who is a hip and knee expert in hip and knee joint replacement. And orthopedics really encompasses all bones. If you break your bone, you see an orthopedist. If your back hurts, you might see an orthopedist or an orthopedic spine surgeon. And it's a great field because orthopedics, the reason I like orthopedics is that we can really change people's lives and get them back to doing what they love to do.
Sure. Well, I appreciate the reminder on the fundamentals there before we actually talk about the orthopedic robot. So with that, it's my understanding from your press release, Tom, that CRMC, the Cuyuna Regional Medical Center, is the first place in the nation where this robotic technology is being deployed. Is that correct?
I don't know if that's entirely correct. We are certainly on the forefront of using the new robotic technology. I'm not sure we're first. I don't know if that's fair to say, but we are definitely up there. And it's super exciting. It's a great new technology to employ.
So you're on the cutting edge, pun intended.
Yeah.
And I'm curious, how exactly does this robot work? How does it get involved in an actual surgery? Tell us about it.
Yeah, so I think it's important to understand how we used to do knees compared to how we are doing them now. Traditionally, a total knee, and robots have been in orthopedics for the last 15 to even 20 years. So it's not, this is a new platform which has a lot of more exciting, different ways to be employed. But robotics in orthopedics is not a new thing. Traditionally, you take a patient, you put them to sleep, you feel their knee, and you kind of look at their x-rays and you make a plan for how to correct their deformity if their leg's not straight, or if they don't flex as much as we want them to, or if they don't completely extend. And we kind of make a plan. We're going to cut 5 degrees here. We're going to cut this at 0. And we give them a new knee. And it's like capping the bone, like capping a tooth with metal and plastic, basically. The new robot, actually, we put in these pins and we use these arrays. And the robotic camera can see what the knee is doing in real time. And that's specific to, Jason, if we were doing your knee and my knee are not the same. And so we get specific feedback from your knee, what your knee is doing in real time while we have you asleep and paralyzed. And we can feel your ligaments, and the robot is telling us on this graph all the alignment numbers and everything that we need to correct your deformity and give you a really good product, hopefully.
So when the robot is in the operating theater, is it actually in contact with me, your patient? And if so, How so? Is it holding a scalpel?
No, no, it's very similar to if you were watching the way they weld new cars in Detroit, right? It's a robotic arm that kind of clamps onto the table. You're laying on the table, put to sleep, you're dressed out, you're all sterile. The robot clamps onto the bed. This system clamps onto the bed and it holds a robotic saw. And what the robot really does is helps us get the alignment of our cuts to be perfect and within a half a millimeter, which is very good surgical precision.
Sure.
And it allows us to get your alignment perfect. The robot does make contact with your body through the tip of the saw, but the surgeon is still holding the saw. The surgeon still has control over the saw and complete control of the entire operation. But the robot gives us so much more real-time information about what your knee does in time and space as we put it through this range of motion.
Interesting. So the robot's role is to ensure that you can maintain a tolerance that you wouldn't otherwise be able to maintain?
Yeah. Yeah. So what the robot does is traditionally we would pin jigs to your bone and then cut our saw through the jig to hold the right alignment. But that's not a perfect science and there's some wiggle room there. The robot doesn't need these jigs. The robotic arm holds the saw in the correct plane for all these different cuts around the femur and the tibia. And it's super accurate. And if you try to overpower the saw, because the saw is still in the hands of the surgeon, which is what we really like about this. It's not like you just put in the information and say, okay, robot, you're up. You do the surgery. No, the surgeon is still doing the surgery, which we really like because this area has been really blessed with good surgeons. Like all of Northern Minnesota has really good surgeons. And this is just another tool in the basket where the surgeon is still guiding the saw. And if the surgeon overpowers the saw will stop if you're out of alignment. So it's just so much more precise.
Well, I want to back up for 1 second because you mentioned something, Tom, that's really intriguing to me. You said that Orthopedics has used robots for potentially 2 decades now. I had no idea. So what's the origin story of robotics in orthopedics?
Well, when Dr. Severson is the surgeon I work with, and we've worked together for about 11 years. His background in robotics is when he was training at University of Utah in 2005. They were using robotics at that time. The difference between this robot and the robot that he trained on is a lot of those were using a burr and they would kind of burr away the bone. This is an actual saw, which is what we like and what we're used to and what feels right in a surgeon's hands. And so we love that it's a thick saw blade that's really accurate. And we love that it's still in the surgeon's hands because this is the person that you chose, that you trust to give you a good product and a good knee and hopefully help you get your life back.
So Tom, are we just talking about knees here or are we also talking about other orthopedic surgeries?
Well, we're talking about knees for today. This robotic platform is right now for knees. It will have a hip application, I believe, in the future. We do use kind of robotic type navigation for hips at this point from the same company, which gives us a really good hip. The hip product that we think we put in, we think is great. And it's a really exciting time to live. You know, modern medicine has never been better than it is today. And the use of technology and the further employment of that, we hope, will kind of translate that great outcome of a total hip to what right now we think is a pretty good outcome of a total knee. We want total knees to be great.
So one of the things that I'm hearing you say is that the saw is still in the surgeon's hands and controlled by the surgeon, correct? Is that done through VR or virtual reality, or how exactly is it still in the surgeon's hands if the robot has the saw?
Yeah, that's a great question. So when we start the total knee, we open the skin with a scalpel, just like normal, do the approach, kind of fold the knee open so you can see the bone and the anatomy. And then we put in 2 little pins into the femur, 2 little pins into the tibia, and we attach these arrays that are about this big, you know, about the size of a large grapefruit. And they pin onto the bone, and each one has 3 pinpoints that like an infrared camera from across the room can see. So there's a base station that kind of holds the saw apparatus. And then there's a satellite station on the other side of the bed that has an infrared camera that's kind of reading down across the patient and reading these arrays that are pinned to the body. And they are watching, invisibly watching the process. And as you move the knee and rotate the hip, the computer is then taking in that information and saying, oh, Jason has a 4-degree flexion contracture, so he doesn't go all the way straight. We're going to want to fix that. It really helps us balance a knee with real-time data that is specific for you. So a good knee will go all the way straight. It'll flex really nice. It'll feel maybe a little looser in full extension, just like the knee God gave us. And it'll tighten up a little bit as you flex. That's how a good knee functions. And that is between the femur and the tibia, but also the ligaments on the outside of the knee and sometimes on the inside of the knee that help balance that knee. So when we can balance a knee perfectly, we think that gives you the best product that will last you hopefully a long time.
You mentioned your colleague, Dr. Severson, is that correct?
Yeah, Eric Severson.
So Dr. Severson had his training that actually included some use of robotics. I'm really intrigued by that because one of the things I wanted to learn more about is to what extent does the medical community train its graduates, its soon-to-be doctors in robotics and automation? Is that now part and parcel of the curriculum?
Absolutely. Yep. You wouldn't want to go to a program that's not on the cutting edge of teaching you what you're going to need to know when you're out there and working on your own. Sure. So he trained at the University of Utah, and they were using robotics in 2005. Then he trained at the university or at Mayo Clinic for an extra year of surgery training in adult hip and knee reconstruction. And so robotics has been around for a long time, but this new platform we feel gives us much more real-time information about you specifically as the patient and what your knee is doing in time and space versus a little more guesswork. But it doesn't take all the control away from the surgeon, because you choose the surgeon that's done thousands of knees, and all of our surgeons up here in this area are good. They're great. And you take that experience and combine it with the real-time data that's specific to you as the patient, it hopefully is a really happy marriage.
So even though robotics and automation has been integrated into the medical training process, isn't it kind of product specific? In other words, if you're using this particular product at CRMC, don't you need additional training to use this specific robot?
Absolutely. Yeah, so we started our training about a year ago. We went to Cincinnati to train on this product, and we're training on cadavers, and we're learning about this robot, how it functions. And a lot of it is what the surgeon's comfortable with, what they trained on, what they think is going to give them the best product, because any surgeon just wants their patient to do really well. So we trained on cadavers, and then more recently we trained on cadavers again, and then we started doing them, and we're really happy with the early results. Now, we won't really know how great this is for another year or so until we see people back. I think our first one was August or September, but you really need a year before you can really look someone in the eye and say, hey, this is way better.
Interesting. Well, that's a great segue into something else I wanted to ask you a little bit more about. As I was reading the product literature, it was saying that the outcomes are undeniably better. There's quicker recovery time, there's better movement and things of that nature. So where's that data coming from then?
Well, that's early data, and we think that's true, but it's a little bit more anecdotally or a little more clinical versus a full 1 year of people coming back. We've been collecting our data on patients since we've been here for 11 years.
Sure.
And until we have a full year and a half even of seeing people back and seeing what they're saying before I could carry in my wood, but it hurt me. Now I carry in my firewood or I chop wood or whatever you like to do. And I do really well with it. And I'm so happy with this knee. Until we have that data on our own personal patients, we're a little careful to say this is 100% better. We think it is. And our early outcomes have been good. People are happy. But until we get a full year, it's hard to look you in the eye and say this is undeniably better without that data.
Well, that kind of begs the question, is this technology proven?
It is. Yeah. Well, I mean, it's FDA approved. And so there's a long process to even be able to try it. This technology, yeah, it's proven for sure because it's been around. The idea of robotics in orthopedics has been around for a long time. Traditionally, orthopedic robotics for knees have used a CT scan, which kind of maps out your anatomy, versus this new product, which uses kind of real-time anatomy that's specific to the patient in the range of motion. A CT scan is a static image of what your knee looks like in just one position. What we like about this is it's what your knee is looking like and doing as we range you from full extension to 130, 140 degrees of flexion. And those numbers change as you move that knee. So none of us live a static life. And the idea of getting your life back through a total knee is not laying on the couch. We want you to be active and get back to what you love to do, whether it's skiing or just working or riding a snowmobile. Or
chopping that wood.
Yeah, chopping wood.
That's interesting. So how many procedures have you done with this robot?
Right now we've done, I'd say 40 to 50 as of today.
And the results are promising so far.
The early results are great. Now, there could be some placebo effect to that. You know, you're getting the new technology. That's exciting. I want that. But we feel a difference when we work really hard and we don't leave the table until we like how that knee feels. And if we need to go back and change something, we always do it. And there are still time. National studies show there can be 20% of knee patients that don't like their total knee. In Dr. Severson's hands, it's more like 6%. And, you know, we'll go, if we have somebody that comes back and says, I hate this knee, I don't like it. We'll go through a process of checking their back, checking their hip, looking at their knee x-rays, taking fluid out, make sure we're not missing an infection. We have a workup for that. Everything looks good, but they still hurt. There's still a small percentage that hurt. And we think the new technology is going to help us hopefully get that number even smaller.
You know, one other thing that I noticed in the product literature was about its role in pre-op planning, pre-operation planning. It says that the tool itself can be useful. How does that work?
Well, what we use is we use the patient's x-rays and we go in with a preoperative plan that we think we know we're going to cut 5 degrees here. We're going to cut this at 0 degrees or 3 degrees for the tibia, whatever it is. And then the beauty of this robot is it's not so much preoperative. It's during the actual procedure where we're reading your movement specific to you and your knee. So this robot has less preoperative planning versus more interoperative kind of real-time feedback that can then be used to make good decisions. On the hip side, they also have a product for hip, and that is very helpful preoperatively to kind of plan what we're going to do for you. And then we take an x-ray after we did it and we make sure it's right and we can change things and stuff like that.
So to date, you have not used this technology for anything but a knee replacement. Is that right?
Correct.
Okay, interesting. Now, I suspect that the robot itself probably costs more than a laptop. Am I correct?
Yeah, I'm sure it does, but I don't have to pay for it. So I don't even know what it costs.
Well, the reason I ask is I'm curious, what exactly is the business proposition for CRMC? CRMC is a business as well. And so is CRMC trying to become a destination hospital for this type of procedure?
I think CRMC's goal with new technology, in the time that I've been here, about 10 or 11 years, I've seen this hospital be on the forefront end of technology, and certainly surgical technology. And so there's kind of this ingrained way of thinking here that if there's something new that may be better, we're going to use it. And the hospital's been very supportive in that. Now, robotic surgery is not a new thing, but this new technology is something that the surgeon, Dr. Severson, is very passionate about because he thinks it's better and he thinks it's going to really help our outcomes and our patients get their lives back. And so he says, I want to try this. And the hospital says, yeah, okay, let's do it.
Interesting.
As far as a business proposition, it's not having a robot does not change the number of surgeries we can do. It does not make things faster or slower. It's just hopefully a better product for the patient. And that's something the hospital's committed to and says, yeah, let's do that.
Well, given the price tag, I'm curious, is this something that's only available to the affluent? Or is this procedure still covered by insurance?
It's covered. There's no change in that for the patient. And compared to old robotic platforms, this is actually quite slick. If you needed a total knee with one of the other robotic platforms that uses the CT scan, then you're getting extra radiation, you're spending extra time coming into the hospital to get a CT scan for preoperative planning. In terms of coding, I don't think there is an extra charge that we use the robot or not.
Interesting. So even if someone were on Minnesota Care, for example, this tool would still be available to them if they were in need of a knee replacement.
Absolutely. And what I like about the way this hospital works is we don't know what insurance you have. As a provider, I know that Jason has a bad knee and he needs a new knee, and we can provide it for him. And so we do that. And we don't change the parts we use, whether you're affluent or not, whether you have great insurance or not. We just treat everybody like we want them to do the best they can, and we give little grandma the same parts we would give me for a hip or a knee.
Well, I appreciate you fielding that question. Now, computer processing, robotics is changing so rapidly. Technology is changing so rapidly. Processing power is governed partially by Moore's law. Isn't your robot obsolete already?
That's a great question. They change so quickly. But the beauty of it is software updates are easy to push out. And as they get more feedback back, and as they get surgeon feedback saying, I don't think this quite is making sense, or I don't understand why it's giving me this number or that number, they can make changes and push out the new software. So I don't think it's been out long enough to be obsolete, but things do change quickly. And the beauty is they can push that out to us with software updates.
So the thing that would become obsolete would probably be the software as opposed to the mechanical tool itself. That's something that you'll have in your arsenal for quite some time, is what I'm hearing.
Yes, the mechanical tool is actually quite simple. It's a robotic arm that clamps onto the table next to the patient's hip. And it very much, you've seen those welders, right?
Sure.
Kind of a robotic arm that goes, and it's very much like that. The saw attaches to the end of it. The saw is still in the surgeon's hands, and which is very important to us, because if we're looking at it going to make a cut and we don't like the way it looks, you got to have that human element to say, wait, stop, this doesn't look right. We haven't had that happen, but it's important to be able to not just turn that over to the technology and say, well, we trust the computer. We still trust the surgeon's brain, the surgeon's experience, and the surgeon's hands.
Sure. So it sounds like it's almost a tag team, really, and this is yet another tool in the toolkit.
That's the goal. The goal is to not eliminate the surgeon's experience, not eliminate the patient's specific biodynamics as you range that knee and things are changing from full extension to full flexion, but to use that experience and to incorporate technology into what the patient is giving you and what the surgeon has learned over the past several years and certainly probably decades of training.
Well, Tom, in the little time we have left, I want to explore a couple more topics, one of which is what's on the horizon. If you're using an orthopedic robot today, what do you think you'll be using, say, 10 years from now at CRMC that's cutting edge at that point in time?
Oh man, that is a great question. And patients are always asking, like, should I wait? Is there something coming up that will change if I can wait 5 years? The bottom line is, if you're hurting now and you're at the point where you've lost your lifestyle, or you've lost the things you want to do, it's probably time to just embrace the technology we have right now. Certainly there are like biologic technologies, which are exciting, both stem cells and ways to regenerate cartilage. They're not here yet, but hopefully by the time I need a total knee, they might be. The other thing with this robotic technology that's exciting is we could help a surgeon in Haiti or any foreign country or any underserved area where we're getting the data that they're showing and we're giving them feedback on what Dr. Severson would do in that situation. And then they, with the help of the robot, can make those cuts and give a good product to wherever they are.
So in
So
real time, that's very interesting. So you could actually support a procedure that's happening elsewhere in the world in real time.
That would be the future for sure. I think the technology to do that is already here. We're not doing it yet, but you know, even just with COVID speeding up this interview, we are doing more Zoom type things than we ever have just in the last 2 years. And this kind of technology, you and I talking together today, can be translated into that surgical, technique into a underserved area. I see that happening fairly quickly.
Interesting. Well, very briefly, if we were to fast forward again 10 years, what do you think the lessons learned will be? Regardless of the innovation, there are always lessons learned. So what might a lesson learned be from the use of this orthopedic robot?
Well, we hope that we learn more specific things for each patient. So to give a knee that is specific for you with your specific alignment and your specific soft tissue balancing and your specific deformity for how your knee is functioning in time and space. 10 years down the road, I would assume that we'll have more AI, more artificial intelligence that's saying, hey, the top 300 surgeons in the world in this case would do this. And here's what we found over the last 10 years that surgeons do for this specific patient, and kind of give that feedback from an AI point of view. But then it's still going to be up to the surgeon to make that decision and make that final plan, and then, instrument the bone and actually do the case.
Tom, this is incredibly interesting. My last question is about data privacy and AI. As the medical community transitions to the use of more and more AI, leveraging AI to a greater extent, do we have to abandon data privacy?
No, in fact, it's very private. Everything we do is very private and secure, and we're very careful about that. Obviously, there's laws that make us do that, but we don't talk about patients to other patients. That information that's stored in the robot is the same level of security as our electronic medical record. It's not shared with companies. If it is, it's blinded, so they don't have patient information.
Sure. Well, Tom, I really appreciate the work that you do on behalf of all your patients in our communities, and thank you so much for helping us better understand the role of robotics and automation at the Cuyuna Regional Medical Center. Thanks, Tom.
Absolutely. Thanks for talking.
You betcha. And thank all of you for joining me once again. I'm Jason Edens, your host of Lakeland Currents. You can tweet us about today's program or future programs at Currents PBS. Be kind and be well. We'll see you next week.